The paper is on perspective of handedness for high dexterity in the practice of ophthalmic medicine and surgery. So the purpose was to assess the perspective and what are the preferences in various experiences of ophthalmic sector people who are using their left hand and right hand respectively to perform routine clinical as well as surgical tasks, which has poorly been reported in literature before. So with that aim in mind, we did a cross-sectional study using the Google platforms, and demographic and practice questions pertaining to handedness was asked. The questionnaire was constructed by 4 people after a focus group discussion. The 4 people were actually different experienced people. One were less than 5, another was 5 to 10, another was 10 to 20 years, and another person was more than 20 years of experience. And there were 2 anterior segment and 2 posterior segment specialities, and then the questions include 22 sets. So this is a sample of the questionnaire that we arrived, labeling from age, current position, whether they prefer a right hand or a left hand, and how are they doing their common procedures like a cataract surgery, gonioscopy, if they use a right hand or the left hand, and a Yark capsulotomy, ranging from very common ophthalmic, surgical and medical procedures. So the methodology was, the questionnaire was sent to 217 persons, out of which 203 people responded. It was a 1-week study period and it was a survey. And the operational diagnosis was right-handedness was defined as people who are using right hand habitually. Left-handedness were defined as people using their left hand habitually, and mixed-handedness who are comfortable with both their hands. So this was the results. Let us see it more deeply. And we are also asked, would you consider ambidextrity a necessary trait for ophthalmologists? That is, do you really prefer whether both hands is very important? The answer was predominantly yes. So then the statistical analysis was arrived, and the details of the trainee and the consultants were divided. And similarly, the ability of the participants to perform clinical tasks with one hand or both hands were evaluated for direct ophthalmoscopy, 90D, 20D, gonioscopy, slit lamp joystick, even foreign body removal, injection of OVDs in the eye, foot pedal in the surgery, which foot did they prefer for the phaco and the microscope, capsular rhexis, and irrigation and aspiration, especially if they are using bimanual. So among the 23 ophthalmologists, you can see here, 73 were trainees and 130 were consultants, and the number of women were significantly higher in the trainee group. A majority of clinicians, as you can see in the third line, considered themselves right-handed. So we had predominantly right-handed majority dominant surgeons in our specialty, at least in India, and the preference, you can see, the preference was a significantly lesser number of trainees, and clinicians with less than 5 years of experience considered themselves mixed-handed. That means there was a very minimal number of people who actually considered that they are using both the hands, so that they always preferred only a single hand compared to both the hands. That was the preference. The perspective, however, 174 participants considered that mixed-handedness was an essential trait, but they preferred that they should use both hands, but actually in the reality they were using only one hand. So there was a difference in the preference and the perspective. In this regard, however, there was no difference of opinion between the trainee and the consultant, that both said both hands has to be used for the surgery for a good performance in ambidextrity. So results, there was no difference between the groups in the perceived ability to perform common outpatient diagnostic procedures. That means the experience in terms of numbers mattered rather than the procedures done. That means more the number they were doing, more they were becoming comfortable with both the hands. So numbers were the only solution for developing mixed-handedness skill and cortical reorganization. In surgical procedures, clinicians who considered themselves mixed-handedness were comfortable in switching the IA between both the hands, and there was no difference for steps like injecting the OVDs or switching foot pedals. However, on the contrary, people who considered themselves both-handedness, mixed-handedness, they were not able to perform a fine maneuver like capsular rhexis with both hands. That was one significant point. So to conclude, mixed-handedness should be developed during the residency period itself. It's a very essential trait. So the sooner the better for cortical reorganization, so that you can see here mixed-handedness will always have its role, and conclusion was it is an indispensable trait in clinical practice as well as surgical practice in ophthalmology was the conclusion of the study, and these are my references. Thank you once again for the opportunity.
presentation. And I think any question from the, you like to pose question? So you mean to say that at the residence level only you have to start the using both hands?
Yes, sir.
Am I right?
Yes, sir. The perspective was different, sir. The preference was actually different, sir. People preferred using one hand, the right hand, but when asked, they felt it is better to use both hands because to maneuver between the eyes, especially when a rent is.
People asking will they help or is there to some punishable acts? Huh? Some forceful. So you have to use the left hand always. Then they can do better, I think. Huh?
Punishable, don't know, sir.
Did you study anything regarding if somebody is left-handed to train? Do they have more learning curve than those who are having?
Ma'am, this was, we underwent a basic pilot study. We took the people who are right-handed and we took the people who are left-handed. So when we compared that aspect of it, we did not find any much significant difference. And it's too early to comment because the number of left-handed people in the study were very minimal. Because our study was more a right-hand dominant study. So with that kind of a sample, it's very, that's one of the limitations, ma'am. We can't comment on that for left-handed people, ma'am.
Thanks.
Yes, ma'am.
Okay, we can move on to next.
Yes, sir. Yeah, this is FP1468, sir. The other one, the 3D digital puzzle assembly for an amplified learning, a comprehensive and a competitive self-learning toolkit. I thank once again for giving me this opportunity. No financial disclosure. So theory has a lot of concepts which has many limitations. When we browse a particular picture like a cavernous sinus or a circle of Willis, or when we verify a lot of books when we refer, there are so many different pictures even regarding ophthalmic structures. So for a neophyte, to start off, there are so many cognitive confusions as to what it is, because certain structures are not dissectable, like the circle of Willis or cavernous sinus. We never get to dissect in our anatomy curriculum. So we wanted to create practical sessions which facilitate critical thinking and coping skills. So we started to construct three-dimensional models. We read the anatomy and then we constructed the model digitally, the circle of Willis, cavernous sinus, the final model of the eyeball, and we felt that just like the kids who give puzzles, when they put the puzzles together, there is an intellectual knowledge which is set into play. Similarly, if we make 3D puzzles, and can we incorporate to ophthalmic neophytes, be it the undergraduate students or even the first year postgraduate to start the curriculum, is it going to really help in cognitive learning? So we used a digital software called Maya to create these models, and we also rendered the slicing in Cura because these two are useful for 3D printing. And then by doing this, as you can see, this is a small clip how we created the three-dimensional cavernous sinus, the circle of Willis, and even the eyeball for that matter. We had to read the Cunningham's and Chaurasia and get the angulations all spot on. And this is the circle of Willis model that you can see in my hand here. So we printed the circle of Willis, which was never done before. 3D printing was done for so many things. I'm not able to bring the cavernous sinus model, but we have all the three models with us. So yes. So we used a Fab Excel printer and a Fab X Plus printer to print the circle of Willis, cavernous sinus, and even the eyeball model for tactile learning by touch and by sensation. We don't need to mug up, we don't need to cognitively imagine how the anterior communicating artery or the posterior communicating artery is coming and joining with each other. We used polylactic acid material to print the models, and once the final model was arrived, we used a red spray paint to paint the structures depending upon which color that they want to. For example, red for the circle of Willis. So this is a model which I just showed, and this is a cavernous sinus model we have done. Just like an automobile engineer, we can actually disassemble and assemble the parts so that we don't need to have any cognitive blind spot, don't need to mug up the concepts, we can have it straight shot. And even we used real-time angle structures. We try to create the fundus images as original as possible so that learning is much better in a very cognitive way for a neophyte. So we did the printing with the retina model was printed with a material of thermoplastic polyurethane, and we can see not only we have normal retinal prints, we have autofluorescence, infrared, for a much holistic learning of different pathologies like a flecked retina, fibrovascular band, retinitis pigmentosa, RNFL defect. We also got feedback from 97 users who are the first year postgraduates, and we divided their satisfaction levels into two. Were they satisfied, neutral, or were they dissatisfied when they studied theory, or when they studied theory along with this kind of a three-dimensional tactile learning, when they touched, felt the dimensions of the curves and learn. Pair t-test was used and it was statistically significant. Student satisfaction with three-dimensional puzzles, they had 97.4% satisfaction levels compared to routine classes where they were pretty okay with that also. It was 89.44, but slightly they preferred something, a novel, innovative way, so that especially for structures which we don't get to dissect in the anatomy, this was a much better way of approach is what the feedback was arrived. And all these models are available open access in meh.org.in for my fellow attendees here. You can go there and you can have this model with you, and you can also print this model, the circle of Willis, which you can see in my hand. You can actually print this own model because the creation part was the tougher one. The model is there in the web and you can print this model. So the economics is, it's very cost effective. This is only 200 rupees and the eyeball costs 1000 rupees, and the duration of printing is 10 hours it took to print the circle of Willis, sir. 5 hours to print the cerebral venous system. For the eyeball, since we had many structures, it took 30 hours. So puzzle making, when combined with 3D printing, we also can have a different field like an automobile or a computer science engineer, where tactile learning will be the future in neo-ophthalmic pedagogy. So once again, I thank for giving me this opportunity. We are currently working on a complex neuroanatomical brain model as well. Thank you, sir. These are my references.
Good, it's very good. I think you must have workshop. Instead of giving a lecture like this, is a practical workshop where people can learn.
Yes, sir. Sir, this year we are.
Yeah, you should talk to the chairman scientific committee and make it a very good one. I think it's a better way of learning. Any question?
So this was recently done, sir. So maybe next year we'll plan on doing.
Excellent. Dr. Priyanka, anything you want to? No. Thank you, Dr.
Just I wanted to
Yes, sir.
ask, are you considering it to be, for different pathologies also?
Yes, sir. Actually, polylactic acid is the material we use for 3D printing, sir. Since we wanted to go for different pathologies, the thermopolyurethane is more flexible material. So we have printed the eyeball in polylactic acid, which is rigid. Now for the retina, what we are doing is we are printing thermopolyurethane, so that if it's a diabetic retinopathy fundus, then we can take that paper out. Then if we have retinitis pigmentosa, we can keep that. So that for keeping the module of single skeleton but different pathologies, we are working. That's one.
Second level as well.
That is also something we have worked, sir. But for logistic reasons, I was able to bring only the one model.
Okay, thank you very
Yeah.
much.
Thank you, sir. Thank you for the opportunity.
Dr. Shalini? Dr. Sharma, it was. Yes. Yeah. Okay. Next. Okay, Dr. Sharma.
JR3 from AIOCMTC1, presenting a case
source of effects are. You didn't get any sign of an acute endophthalmitis when the patient developed, it has gone to barometer still more than 24 hours. So within these 24 hours nothing could be done?
Yes, actually, sir, what happened? The patient was admitted in ICU, so this ophthalmology symptoms were ignored in that setting. RA call was sent after 5 days of ICU.
Any other patient developing the similar symptom in the ICU? Did you find it? Did you try to find out if any other patient also developed any at that point of time?
Any other
During
patient?
dengue time, we noticed with the span of in ICU patient, dengue type.
At the end, where you would be able to save the eye or not? No.
Okay, thank you very much. You are non-registered member, so this not included in the competition. Okay?
Not included.
This paper is not been included in the competitive section. You are not given any marks. That is because you are non-registered member. Okay, next. Dr. Rashmi Kumari.
So good evening all. In the next few slides, I will be presenting my work evaluating tacrolimus and interferon in cases of vernal keratoconjunctivitis. I have no financial interest. VKC is a commonly encountered disease. Basically, is a self-limiting disease, but certain situations we have certain cocktail of the pharmacological agents which are needed for its management, including steroids, which are needed sometimes to be given in long terms, which has inherent side effects like cataract, glaucoma, and secondary infection. But even after so much of medical options, we have some set of patients which do not respond to any of these pharmacological agents, which we call recalcitrant VKC, for which we have another class of drugs called immunomodulators, basically comprising of cyclosporine and tacrolimus ointment in different strength. And past few decades have investigated these drugs and and tacrolimus especially has found its role in a clinical management of such patients. But the problem is longer duration of treatment and withdrawal effects. As soon as we withdraw these drugs, the symptoms reappear. So newest member in this category, which is now investigated, is interferon alpha 2b. So we have also tried to evaluate and compare the efficacy and side effects of tacrolimus with interferon in patients of recalcitrant VKC in a prospective non-randomized comparative clinical trial from March 22 to August 22. Verbal children with active disease who were not responding to disease were included, but those with any coexisting ocular disease or any systemic disease except coexisting allergic rhinitis or any hypersensitivity were excluded from the studies. After getting ethical clearance, all the drugs were discontinued for a washout period of 2 weeks. Basic ophthalmic workup was done when the total subjective symptom as well as sign score were scored, and then the patients were assigned to one of the two groups. Group B was preferably given to the patients who had facility of cold chill maintenance. Follow-up was done by 2 weeks, 4 weeks, 6 weeks with drugs, and after withdrawal of drugs at 8 weeks. Main outcome measures were total subjective symptom score and total objective sign score, with secondary outcomes like side effects or recurrence of symptoms or signs. Classical method of grading by Blake et al. Was utilized for grading of the symptoms and signs, and grading of 0 to 3 was assigned depending upon the degree of severity. Similarly, adverse effects were also graded. Now coming to the results, a total of 32 patients were analyzed, 16 from each group. Male predominance was seen in both the groups. As far as age and duration of disease was concerned, both the groups were comparable. Tarsal variety of VKC was most commonly observed in both the groups. Total subjective symptom score and total objective sign score at baseline was comparable in both the groups. There was a consistent decrease in total subjective symptom score till the patient was on treatment. After the withdrawal of the drug, it was seen that the subjective symptom score showed upsurge in group A, while that symptom score was maintained in group B. Similarly, total objective sign score showed an upsurge after withdrawal of the drugs after consistent decrease with treatment in group A, and it was maintained in group B. There was no significant side effect in either of the disease, for which we needed to discontinue the drugs. Coming to discussion, as I said, interferon is recently investigated in cases of VKC after its established role in the treatment of OSSN, and very handful of literature is available. Starting from a case report, Turan et al. Was the first to evaluate it in cases of 12 cases of for 2 months, in which he found that treatment was safe and effective. Janjani et al. has evaluated different strength and formulation of tacrolimus with interferon and has concluded that both the varieties are effective and appear to be safe. Most recent study in this category is that done by Gupta et al. They have investigated tacrolimus ointment with interferon 1 milli international unit, but the study design was different, and they have even concluded that interferon has greater improvement as compared to tacrolimus, but in our study we found that both tacrolimus and interferon were equally effective, but it seems that the later seems to have more sustained effect in patients with decalcitrant. But the limitations of our study is short duration, non-randomized study design, and smaller sample size. But still, it has aroused a ray of hope in such patients, and it needs further larger randomized control trials with different duration and strength, and obviously economic considerations has also should be taken into consideration. Thank you so much.
Thank you very much. So your study, did you get interferon? How to prepare
Injection, sir, it was formulated with mixing it with artificial tears. It is available in 3 or 5 million international units, and what we use in eye drops is 1 million international unit. It has to be formulated.
available in the market?
No, it's not available as drops.
What is the duration of time? You said that the results are equal.
15 days. 15 days for one formulation. After that, the patient were called, they were again given another one.
At the end of which time, whether 4 weeks, 6 weeks, or 8 weeks, you said that both the results are good.
At 6 weeks.
Huh?
6 weeks.
And there's nothing better in the interferon group or liquimus group, which is better compared to?
According to my study, both were comparable.
Okay.
But sustainability effect was found in interferon group.
Okay. Normally, the PKC is mostly seasonal. So, and if you have started in the middle of the season, can you probably the natural course, the disease come down. not
Yeah.
because of the drops.
But that will be generalized for all the patients, sir. That will not have be limited to a particular group. That will be universal for all the patients. That factor, common factors will be common for all the patients. Seasonal effect or anything else like that.
Usually comparatively better at the end of the 4 weeks or 8 weeks, and maximum better after 8 weeks only.
The sir beneficial effect started showing from 4 weeks onwards, and at 6 weeks it was significant when compared to baseline in both the groups.
One query. The type of patient, which type of patient either treated previously?
So,
someone
and
already different
sir, recalcitrant. Those were on treatment, but they were not responding.
What do you say about the recurrence is very common in BKC, and
Yeah.
we often treat the patient.
Recurrence is another thing, sir. Non-respondents are another things. Recurrence is different, but non-responding patients are different category.
So do you advocate or suggest to start these drugs as a primary treatment?
So I have another study also, which I am using these drugs as primary treatment, not interferon, but of course cyclosporine and tacrolimus.
Thank you very much.
Did you need to use steroids or something previously on these patients, or just
No. I had to wash out every drugs. And during this course of 2 months, I didn't use had to use steroids for any inflammatory factors.
That is like this drug, alpha interferon, is also notorious to cause some itself follicular conjunctivitis.
Yeah. But
So how do you differentiate this irritation and follicular from this VKC that is drug induced, whether the patient is subsiding? You did interfere
Okay.
with your study.
actually, in my study, I didn't get any. But if I had to encounter such patient, I could think that these type of patient could initially start showing improvement. Then again, if there is worsening, that could be attributed to the drugs.
Okay, thank you very much. Thank you very much. The time is up now. I think we'll just move on. So
Thank
Dr. Arvind Roy, is he there? No. So next is Dr. Vidya Bhushan Kumar. Please. Yeah, please.
Good morning, sir. My name is Selling the Tsunami of Mucormycosis. Selling the Tsunami of Mucormycosis. I have no financial issues. During the pandemic of second wave of COVID-19 in the mid of 2021, a myriad of manifestation of complication had emerged and been reported. One of the most devastating and life-threatening complications was random cerebral mucormycosis, commonly called black fungus. As the worst phase of the COVID-19 stabilized, sudden surge of ROCM reported everywhere in India, which left thousands dead and disabled. Mucormycosis is a leader invasive fungal infection predisposed to the diabetes related corticosteroid and immunosuppressive and primary and secondary immunodeficiency. The incidence of rate of mucormycosis globally was 0.005% to 1.7% for Indian population, whereas in India 0.14% per thousand, which is about 80 times higher than the developed country. The fatality rate is also high, around 46% globally. My objective was to assess the risk factor associated with the mucormycosis and to see the characteristic clinical features and outcome of the disease. The study design was placed mucormycosis was IDLS partner, and the study done hospital-based study. Total 161 mucormycosis patients admitted to the 16 May to 18 June 2021, and we collected data, pre-designed questionnaire and filed for admitted patient. Data analysis was done with MS Excel 2020, and the clearance was taken. Inclusion criteria: all patients admitted to the diagnosis of AIOCM for treatment of IgMs, and all patients are giving informed intent consent. If historical, so the negative for mucormycosis and negative for not giving exclusion criteria. My presenting complaints, but eye complaint was present most commonly with 52.8% patient, cheek swelling was present in 23.6% patient, toothache was present in 20% patient, and nasal bleeding came with the nasal bleeding 23.2% patient. Data analysis done in the form of distribution of the according to age and sex. We find out that majority of patients came with the young patients, like between 40 to 60 years of age. So 55% patient was 55 to 41 to 60 years age, and other than young patients with 20 to 40 years age. Male was predominant. Distribution of study subject based on the risk factor, we find out that 60% patients, about 60% patient was diabetes, and 40% patient was non-diabetes. But out of 40% was non-diabetes patient, more than 90% was hyperglycemic state, unaware of the safety diagnosis about the diabetes. 60% patient was hypertensive, and almost 98% patient was COVID-19 positive. 1.87% was not positive, but they not the history and proper history, but they have taken the medication for the fever. Oral corticosteroid was taken by 89% patient. IV corticosteroid was taken by 52% patient, and O2 requirement was around 52% patient. Continue. Mean duration of the symptom of mucormycosis was 12.9 days. 90 days. Out of 161 patients, 12 were vaccinated with 14 single dose and 1 double dose. During the hospital stay, 74% patient had stayed for more than 3 weeks, and 32% patient on oxygen support. 6 patients were diagnosed with pulmonary mucormycosis. Treatment was given according to the protocol that time made, and but all patients were given intravenous amphotericin B. Dose of amphotericin B was 5 mg per kg body weight, and selected patient was given retroviral amphotericin B. The early debridement of the involved tissue was done in almost all cases. With the early stage up to stage 2, where only PNS was involved, endoscopic open sinus debridement was done. Those cases where orbit was involved, along with the loss of vision or arterial regeneration was done. And cases with stage 4 craniotomy was also done. So this is the interpretive picture. Here picture taken from the images, and we can see that nuclear involvement and fungal involvement is there in paraneal sinuses, and even retrovital area everywhere we can see. And this is the post-operative picture, but not good picture. But this outcome is devastating, and we lost a lot of eyes. This even young patient came with severe blackening, and after removing everything, so one-sided full craniotomy, orbital regeneration with maxillotomy done. Some patient was happy and with retrovital amphotericin B, so we got. So final outcome came in the form of orbital regeneration was done in 42%, 26% of patient. Craniotomy was done in 6.8% patient. Open endoscopic sinus debridement was done in all patients. Mortality rate was in this study was 17.4%. So coming to the discussion topic, my point came that hidden culprit was there in mucormycosis. Was first per se COVID-19, second is hyperglycemia, and third is maybe because of the
time is over. I think the conclusion
is over.
Good conclude.
No. started in the treatment of COVID pneumonia, post-COVID patient, routine monitoring of blood sugar along with the routine examination is must.
Dr. Priyanka, what else?
Was it, in your case, was it a pure ophthalmic involvement or other sinus involvement also?
In my case was sinus involvement also, sir.
Sinus involvement.
ENS cardiac sinus involvement.
Because we face so many cases in our institution also. Our combined ENT and neurosurgeon operated so many cases at our center also. So we are also experienced of the fertility of this such kind.
This was an emergency procedures you were doing, so you must have taken the ethical clearance and all these things.
Taken the ethical clearance at that time.
You have taken the ethical clearance.
Yes, we have taken.
How can the ethical clearance be given when there is no protocol as such for? I mean, nothing was. I mean, whatever you did.
Post-COVID came post-COVID, sir. So that time.
If you have not done, you can mention it. You have done.
I have taken. I have.
Okay.
Any other presenter here? Dr. Pallavi Sinha, Dr. Puneet Singh, Dr. Nikhil Agarwal, Dr. Rupali Barwa. Thank you very much. Thank you very much for the presentation.
I knew it, that's why I was asking. So I just wanted to have some question with Dr. Rashmi. Dr. Rashmi, since you have done this study, so you have seen patients improving with steroid and you have seen the patients who were off steroid and on these two medications. So do you feel the level of resolution is similar? Because I just wanted to ask you, you are thinking of starting as a primary therapy. So what were your observation in those times? Whether it respond like a steroid or it takes longer time?
As a first line,
Yes.
as a first line symptomatically, contrary to what my belief, it would take time.
Yes, that's what my belief is also.
Yeah,
That's why
but
I'm asking.
That was a surprise to me that
Hmm.
patients were comfortable. Those signs were not that improved, but
Mhm.
patients were comfortable.
In what sense?
In sense of redness or whatever foreign body sensation and
See, what we have gained till now, that we treat VKC almost always with the steroid, and these all these things are steroid sparing in the sense that if the patient, because these are chronic diseases and you have to keep the patients symptom free. So for those period, to spare steroid we use all this. So you are not using it as a sparing steroid. In fact, you are using instead of steroid. So I mean, if at all, if your studies, I mean, comes to the practice, it would be good that people will be off steroid and
I
steroid.
have started using this as primary treatment after my first study.
So now the question is, in which patients? I mean, if you start in a
Especially in those patients whom I suspect for follow-ups.
no, what I'm saying that if your study group is of the patients who are having milder sort of symptoms, they will anyway
No.
These are all
For
seasonal
moderate to
diseases.
severe,
Yes.
I had mentioned that TAS and TOS should be more than 4 and 6. But grading of symptoms should be done in signs, and if they belong to moderate category, so subjective symptom score is more than 4, sign score is more than 6. Then only we have to use steroids for either of these two drugs. For mild cases, we don't need any such.
Yeah.
We ask for mild lifestyle modifications, lubricants, they are sufficient. For moderate to severe groups, we need treatment.
Did you also compare for the time taken to get relief of the symptoms between these two groups?
I have not compared steroid with this because there was one thesis going on.
I think this study is basically to compare between the two drugs,
I think
these
the duration
non-sparing
of
drugs.
coming down
What
the
I am
symptoms.
interested is in comparison with steroid and then with
Did you
any of
publish
this.
this later?
We are as far as this study is concerned, it's not over. This is only a part of my research, and we are following those patients.
Good.
We intend
Yes.
to get
Exactly.
So, anyhow, if suppose I am treating the non-steroid drug, the patient goes to another doctor, where he prescribes steroids. There is a remission. Steroid,
This is
at
the
least
thing,
short course of steroids.
sustainability of effect. As soon as patients are on drugs, they are effective, they
Yeah.
are relaxed, but as soon as we withdraw, after they stop the drugs, they are again having symptoms. That is the query why we investigated another molecule which is showing encouraging results. So does this have any effect, especially on sustainability? And if it's, then it can be cost effective in long term.
True. Otherwise, it is very
Otherwise,
costly.
very costly and
It's too
its
costly.
maintenance and logistic issues are so.
Even the OSSN patient most of the time don't take this.
Don't
They
take this.
basically prefer
These are
mitomycin.
practical problems. Everyone should have refrigerators. They are not formulated and available in the markets.
Yeah.
So there are so many problems in interferon. But if it has any extra edge over all those, then we can have
One
Any,
more
any
option.
number of patient you need to convert to the conventional therapy amongst your study.
we are not in this short study. But let's
No,
see.
it's a really too short study. Unless you,
Too short to comment on
Nice,
those.
nice presentation.
at least 2 seasons you have to do
Yeah,
that.
yeah,
Then only you
definitely,
know
sir.
that whether it's effective or not.
On drugs, off drugs, what was the duration of symptom-free period, and at what time they again come up with, because there is inherent mechanism also that is going on in every patient as they are aging.
Yeah.
True.
Age
So
Yeah.
all those factors are confounding,
True.
and that needs to be excluded, and it's very difficult to exclude.
Yeah.
So next study you can do is the steroid versus any
But
other.
Yeah.
yeah,
That would be the
better said.
yeah.
But nice concept.
Yeah, it's good.
Just a thought.
Something new.
Any comments on this from the audience, please? Your experiences while treating the VKC patients, because we see in our practice every day VKC patients. And our practice is incomplete without seeing any VKC patient in our life. So any comments from anybody would like to share? Please. Please be seated.
I would like to speak in Hindi only.
No problem. Good.
ये जो पेशेंट्स होते हैं, मैं 41 साल से ऑप्थेल्मोलॉजी प्रैक्टिस कर रहा हूँ। तो ये पेशेंट्स ईयर्स टुगेदर सफर करते हैं। तो इनको ये पेशेंट को अगर समझा दिया जाता है कि ये एलर्जी क्या है और किन चीज़ों से आपकी दिक्कत होती है, उससे अगर हम बचने की कोशिश करते हैं, तो दीज पेशेंट्स डू बेटर। उसके बाद मैं उनको ऑप्शंस देता हूँ कि देखिए आप जैसे ही आपको थोड़ी सी भी दिक्कत लगे तो आप ये आप स्टार्ट कर दें लुब्रिकेंट। उसके बाद दूसरा ऑप्शन आजकल वो मैं देता हूँ यूजुअली ये ओलोपेटाडीन और उसके बाद उनके पर्चे पर मेंशन साइक्लोस्पोरिन भी रहता है, मेंशन ये टेक्रोलिमस भी रहता है, और उनको कहता हूँ कि इससे अगर नहीं रिस्पॉन्ड करे तो यू कैन ऐड दिस। तो देखता हूँ कि पेशेंट सेटिस्फैक्शन क्या दे रहा है।
Great. Yeah. So, but because always we have to give a short course of steroids, followed by anything additional, tacrolimus, olopatadine, whatever the drugs. If you do a primary treatment with these drugs, but they are not responding. They will not respond. If you feel that the patient is responding, the patient is happy with you, no, patient not happy with you, he has gone to some other doctor, where he has prescribed steroids. So this is the usual thing to come from doctor to doctor and till they get cured of the major symptoms of because although the child comes, a mother parent comes with the child rubbing his eyes during the study hours, in the evening hours. When they come home from the school, they get a lot of irritation in the eyes, redness, watering, etc. So they bother. So we have to give steroids, a short course of steroids. Chloromethadone steroids are the best we can give.
नहीं तो फर्स्ट टाइम तो जो जब पेशेंट आता है तो उसको स्टेरॉइड देता ही
Yeah.
लेकिन फ्रॉम फ्यूचर
Towards
और
follow.
फ्यूचर उसको
True.
ये समझाता हूँ
Yeah.
कि if you do like that,
I
you
think
will not have to
making
come.
the patient aware of the thing is most important in VKC
Sure,
because
right.
they
Yes,
switch
no.
on one to another to another.
The parents they go on giving steroids without our knowledge.
Yeah, that is one thing
They
they
have to
have.
get to the market. Then this drug is very effective.
Should be discussed.
So what I tell the patient, there is no treatment for your disease. I am not treating you because there is no treatment for allergic disorder. That will
But
remain.
if you say
And
you will go to the next
any
neighbor
neighbor,
doctor, you want to-
but then many patients come after showing others. So I tell them that I will not be able to treat your disease because your disease is self-treatable. It will go away in course of time.
They want
So what I am treating is your symptom.
That's true.
So that is again important.
एक चीज मैं और कहता हूँ अपन पेशेंट से कि जब भी मैंने स्टेरॉइड दिया तो कहता हूँ कि इसको आप अपने से कभी मत इस्तेमाल
हाँ.
You will end yourself in trouble if you use it on your own. These are disastrous drugs.
But only thing I would like to say that over the counter this steroids should not be given.
True.
So we have to put instruction to this medicine shop, pharma people not to give the steroid drops without.
It's the other way around, sir. The steroid antibiotic combinations come under drug pricing control and it is available in
Cheaper.
10 rupees, 20 rupees. So they always take.
Sometimes
Rather they should make it more this thing.
I had a paper with Pyare Mohan. You know what is Pyare Mohan? People ask I used Pyare Mohan. Pyare Mohan. And the Pyramon drop was available 6 rupees, 7 rupees at that time.
Yes.
Some 20 years back, Pyramon was one of the best drop because it is still in
It is
combination.
still.
So they said that Pyramon, I used Pyramon.
That is the reason what the disastrous fungal ulcer we have
Yeah.
treated.
Right.
Putting steroids and melting the ulcer.
So Dr. Vidya Bhushan, we had some time to discuss because we had to kill some another 5 minutes. So your presentation was really good. So mucormycosis, everybody is faced during this 2 years, last 2 years, lot of cases we reported, lot of cases ended in the losing the eye, even sometimes like death also. So
But I have a question, not to him, to the
yeah,
everybody.
please, but we'll later have discussion.
Yeah.
If somebody comes.
So the COVID is still there, patients are still there, but why are we not getting even a single this thing? It was just an enigma. How could the patient be getting so much of this thing?
So that's
paper?
why my discussion first point was COVID per se, that was there, sir. That's maybe the cause and in advantage of
So what I am saying, the COVID is still there.
No,
COVID has
no,
not gone.
No, COVID not there.
No, what I mean to say that after that period of say 3 to 6 months, there was a COVID, but it came as a something like booth and it went away. So that was basically.
Still, we are getting 1 or 2 cases in Nigeria, sir, but that is very rare. Means ENT department they are getting.
Any report of post-COVID mucormycosis now? I don't think anybody is reporting mucormycosis.
In the symptoms of long COVID, what we call it, do we have?
We have 1 or 2 cases in the ENT department they reported and they came to our department.
When? This period?
Not this period.
Ah.
We are not.
I don't think 2022 anybody reported mucormycosis. I don't know. I don't have knowledge. Maybe literature can
I am also not having documentation,
Yeah.
but we have seen the ophthalmological part. We have seen so from ENT department. They are
So,
saying-
I mean, since you have done a study, now you tell me, what do you give the most important risk factor? What was, there were so many talks like it was from the oxygen, it was then another thing was it was of the steroid, somebody said it is because of the unhygienic mask. So what do you think was the main cause?
So my cause was only hyperglycemia state because of the metabolic imbalance. Because I have seen cases of that was the real data, and I have seen the patient came to emergency department there with blood sugar was 800 blood
So
sugar.
in community also we have people with 800. See, otherwise, take away this corona, there are people who have 800 but they don't develop so frequently mucormycosis.
Yes, sir. Maybe some metabolic is.
So and the other thing is all those who got diabetic with corona positive many of them are still diabetic.
Yes, sir.
So but they are not coming with the mucormycosis. It was something like it cannot be explained.
I have put on case that was the doctor surgeon, very famous surgeon, and he was very in anxiety state and he called everywhere and we have.
But I tell you, in that time there were many patients who were not having a high blood sugar, not hyperglycemic, and still had this thing.
Only 3 or 4 cases.
No, in your study, but the representation, but the report were there. I think
Okay,
we are-
thank you very much.